Hello everyone, my name is Tomé. I'm a consultant cardiologist and professor of practice of cardiology at St. George's Hospital in London, and it is a pleasure to talk to you all today about the athlete's aorta, and let's learn about differentiating physiology from pathology. Let's start with an impactful message from what I call the Flo He-Man effect. Flo was a professional volleyball player who sadly died in 1986. She collapsed during a volleyball match in Japan, and it took 2 postmortem to reach a diagnosis. She actually suffered with Marfan syndrome. Thanks to her, her brother and other family members had life-saving operations as a result of her diagnosis. It is that an acute aortic dissection or rupture or Marfan syndrome or other aortopathies is an important cause of sudden cardiac death in athletes. We need to understand that increase in the blood pressure and aortic stress during intense physical exercise might place the patient with Marfan and Marfan-related presentation or other aortopathies at risk of aortic dissections or rupture, or might accelerate aneurysm formation. Therefore, discussion of safe level of exercise must be part of athlete care. What's the physiology? Aerobic exercise produces only a modest rise in arterial blood pressure of 100 to 160 millimeters of mercury. Highest level of exertion, however, will be a higher increase on systolic blood pressure, up to 200. We know, however, that transient acute raises in blood pressure over 300 millimeters might happen with weightlifting involving deadlift or rises over 50% of the world body weight. How this affects our aorta? It is of interest, this paper, where they looked into the mechanical deterioration that underlies the malignant behavior of aneurysmal ascending aorta. For this, they observed the behavior in terms of mechanical distensibility of pieces of aorta obtained for patients who have undergone to CABG or actually aortic replacement surgery. They looked for elasticity of the aorta and the aortic wall stress, and they were shown that the elasticity reduces significantly from aortas who have already dilated to 5 centimeters to almost minimal distensibility above 6. And that means that the aortic wall stress raises dramatically with increasing aortic dimensions. Extrapolating what's the equivalent of blood pressure by doing different type of experiment, blood pressure of 20 with an aortic root diameter, it will increase significantly the stress of this aorta and increase the possibility of rupture. So these tissue strips showed the maximum tensile stress that aortic tissue could withstand, and therefore that's actually one of the bases where avoiding sport that can reach the blood pressure and the stress that are put into the aorta over 200 millimeters of mercury or require Valsalva is the current advice for patients with aortic diseases. Is aortic dilatation path of the athlete heart? We know that athletes, we recognize athletic remodeling in the heart, but it is the aorta part of that remodeling. We have seminal studies conducted by our colleagues, and I will highlight these studies done in 2020 by Antonio Pelliccia, where 2,317 Italian athletes that they were under follow-up with a wide range of ages and for many different sports, up to 28 different sports had the aortic root and aortic dimensions measured, and they established that a sinus de Valsalva in males more than 40 or a sinus de Valsalva in females more than 34 millimeters was relatively uncommon, with less than 2% and less than 1% in females, respectively. And therefore, when this is found, we should acknowledge that that might be a pathological manifestation, and surveillance, therefore, is recommended. You can see this in a graphical manner, where there is the distribution of the aortic dimensions in most of the population, only reaching 40 or plus in a very small number of patients. They also showed that there was relationship within the height of patients and the aortic root, and although at that time they were normally indicated by body surface area. When they look at the type of sports, that there was only a limited influence on the aortic dimensions, but there was perhaps the aortic bigger dimension was found on high intensity endurance exercises, like, for example, cycling. There were other disciplines like weightlifting, throwing event, that they have, if anything, only a trivial effect on the observed values. Was this study conclusive? So we also referenced the further studies some years later, where Iskander looked into a meta-analysis of the aortic root size in elite athletes. This is looking for a largest data set, about nearly 600 athletes and 23 studies, versus control in 13 of those. And though these observations had limitations to mainly European ethnicity, the conclusion was similar, that the aortic dilation more than 40 in athletes was rare, and the ranging reported data was anything from 0.26 or 1.2. But in those patients where aortic manifestations like dissection or rupture could be the first manifestation of an aortic dilation, and the risk of those complications increase with aortic size. And in some cases were undiagnosed syndromic or aortopathies. That conclusion, that the meta-analysis conclusion, established that any aortic root enlargement that occurs with exercise training is small, and a large increases in the aortic size are not produced for exercise training alone. It was important that we also realized that there were some statistical enlargement. However, there was not an association attributable to exercise alone. Interestingly, the study performed years later with Savia and Sharma team at also a large group of young athletes, so this is under 35, putting together nearly 4,000 athletes ranging from regional to national level, many sporting disciplines, comparing them with sedentary controls, and done by echocardiography. They found also that large aortic dimensions in the athletic population was rare, with less than 2% in males and similar data in female athletes. More importantly, those non-progression for a large period of time was also significantly associated to lack of aortic events. So we have lots of data to suggest that although minor findings might be present, minor dilatation might be present, and including some literature might show some statistical difference. In reality, clinically relevant aortic dilations are rare in athletic populations, and in fact, we might actually pay attention to whether there is a significant or an alternative explanation to support this, and we might have to follow the patients. But let's advance on these conclusions. What are the determinants of the aortic dimensions? We know that there might be age, sex, face area, height, genetic factors. But have we actually looked properly in the type of sports? This study is also relevant where Dr. Boraita looked to a cross-sectional study on elite athletes and where a large proportion of them were male, particularly young, and whether the aortic dimensions and they had in any relationship with the type of sport classified, as you know, for the dynamic component and the strength components. Again, in this study, also in young patients, only less than 2% of males have an aortic root dimensions of less than 40, and 1.5% of women more than 34. It was found here that greater sizes in athletes were found with the participating in a sport with high dynamic components, as well as the index influence on the size of aorta. Later on, as you know, it is important that we recognize that largest humans might have largest aorta, and smaller humans might have a smaller aorta. To what extent I'm happy to attribute the size of aortic root to height only. I think it's important also to remember that the physiological sizes of the aorta, and this study is relevant because it was done in basketball players, and those are all tall. However, in those who had clinically significant aortic dilation, in that case, even index case was more than 4.2, and females were more than 3.4. Genetic testing was considered for purely finding of aortic dilatation. And patients, were found at least were found to be carriers of a fibrillin 1 mutation, and as you know, is a marker of Marfan syndrome. And other patients were diagnosed with other familiar aortopathies. It is important to bring into account that when we talk about the aorta, we cannot forget one of the most important risk factors of progressive aortic dilatation, which is time. This would translate that those patients who have been found some aortic dilatation and might not have had a significant clinical progression for a number of years, they might still need follow-up later on in life, as you might see that as recent publications in master athletes have found that some of those actually present with typical presentation that we recognize in the general population, like a non-syndromic thoracic aortic dilation. And in fact, they might be present for many years before, at least 20 years before, of a more severe aneurysm formation of the aorta. So bear in mind that the surveillance might actually need to happen for many years. With this, I hope that you have taken into account that on the presence of aortic dilatation, although we might recognize that Your athletes might have a slightly aortic dimension for the same individual in the same population. However, clinically significant aortic dilation, even in sports, is rare and therefore needs careful evaluation to try to achieve a diagnosis, etiological diagnosis. The best plan is to continue follow-up and then to remember that age in aorta might be a long shot, and in fact there might be a recall every 5 years for those who have aortic dilation and prevention of cardiovascular risk factors. Thank you very much for your time and for listening to me today, and I hope that this is useful for all of you.